before we get into the episode, I've got to tell you about something that I use all the time, and that's my X shears. These aren't your run-of-the-mill trauma shears that bend after one tough shift. X shears were designed by someone who gets it. A nurse and paramedic who is just tired of disposable junk and clunky tools that never held up. Y'all, these things are beast. Heavy duty, stainless steel blades, the titanium coating, super comfortable non-slip handles, and yeah, they come in a bunch of colors, including my favorite, purple. They're easy to clean, built to last, and come with a 5-year warranty, which is basically unheard of. And this is new, the X Shear Mini. It's only 6 inches, and it fits in your pocket or a small kit. It still cuts like a champ, but it's perfect for those lighter situations where you don't need the full-size version. So, wherever you care for patients, you want a pair of shears that actually work, and X Shears is it. I promise they'll be your new favorite shears. And you can use the code RAPID10 to get 10% off your purchase. So check them out. I put a link in the show notes for you.
I've shown up to patients who are satting at 70%, and the nurse is like, well, I didn't want to give them oxygen because I didn't want to knock out their hypoxic drive. Can you just speak to that for a minute?
I so feel your pain because this myth will not die. It's one of those within nursing school that I wish I could just tour the country and just go to every single nursing college and be like, this is out of your curriculum, yes? Okay.
Hey there. I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Today, we're diving into the world of ventilation with someone who lives and breathes this stuff, like quite literally. Respiratory therapists are one of the unsung heroes in critical care, and as nurses, we collaborate with them constantly. But there's still so many myths and misunderstandings and old dogma that just get in the way of optimal patient care. So today I'm joined by Melody, an experienced respiratory therapist with a passion for education and a willingness to call out outdated practices. We're going to break down ventilation misconceptions, spontaneous breathing trials, COPD management, oxygen strategies, and so much more. Hopefully many side quests. I'm super excited for you to hear from Melody. So Melody, welcome to the podcast.
Well, thank you so much for having me, Sarah. I'm super excited to be here, and I'm very, very passionate about teaching outside of the RT sphere. So talking with a bunch of nurses is where I love to be. So I'm really excited for this.
Yes, we have a lot we can talk about. So I know that I have my own pet peeves and old dogma that I constantly find myself smashing, but I'm kind of curious, what are yours? As an RT, what are the things that you hear that you're like, oh, they misinterpreted that literature, or that's not exactly how it is from the physiology perspective? What are your top couple of things that you find yourself constantly addressing?
Well, I think one of the ones that I proposed to you when we first chatted about this podcast was specific to the intensive care unit and mechanical ventilation, is this idea of resting patients. That is probably something that I have to address almost every shift. And it is insane how pervasive this concept is, that mechanical ventilation and control ventilation specifically, where the machine is fully breathing for the patient, is rest. That is probably number one.
Okay. I think mine is probably COPD and hypoxic drive, and the idea that if you give a COPD or oxygen, they're going to stop breathing on you. I remember my nursing professors telling me that, and it got really ingrained in my head, and it took me years to get that old dogma out of my perspective and how I approach COPDers. So I hope we can talk about that today. Any other topics that you're we need to open this up?
I'd love to chat a bit about sedation and mechanical ventilation. So that will be a little bit more intensive care side of things.
Okay.
But that definitely is a huge piece. But more than anything, I think the one myth that I'd love to chat about is this idea that mechanical ventilation is too complex or the respiratory system is too complex. Because I know it's something that I hear constantly, even when I'm going out to the floors to see patients, that there's like this black box of the scary that is anything to do with respiratory, trach patients, anything to do with patients who are short of breath, that they call the RTs and they look to us like we're some sorts of heroes. But realistically speaking, it is so simple when you have someone to walk you through the concepts. And I just would love to address and myth bust that it isn't complex. And every single nurse and clinician within the hospital has the capabilities to jump in and be a lot more engaged in that side and not necessarily have to depend on the RTs to do that.
Okay, I love it. Let's do it. Well, that's a good starting point. The other one I want to talk about is BiPAP versus heated high flow nasal cannula. I find us, at least in the rapid response world, constantly debating between like, oh, which one should we put the patient on? Here's the ABG. Should we go to BiPAP? Oh, not so much BiPAP. Maybe we should do heated high flow. It's like a constant debate. So maybe we could talk about that as well. All right.
Sure.
So let's start with the basics. If you were just wanted to like make like just to level set everybody to understand ventilation and oxygenation so that we can use that knowledge to talk about heated high flow, BiPAP, like all the things, the ventilator, all the things. I'll let you just take it from there.
Yeah, like just the very core building blocks of what we're doing when we're breathing. I normally break it down. Like I think everybody understands that when we breathe, we're doing two different things. We are trying to bring enough oxygen in for every single cell in our body to run. Like I like to describe oxygen as the gas, right? It's the gas that keeps our cells moving and doing all the things that they need to do and all the cellular functions that keep us alive. And if without gas, the car is going to not go anywhere. So we need that oxygen. So number one, that's that. But then the garbage, the waste product of every single cell is going to be our CO2. So then we need to also clear that. And the lungs have that dual purpose, bringing the oxygen in and clearing the CO2 out. But when you actually dive into all of the different nitty-gritties of how that actually, the lungs are over here. And if you're listening to this, you're obviously not seeing that I'm putting my hand on one side and then the cells are way over here. How does that actually happen? So you breathe in that oxygen and breathe out CO2. And that's, tidal volume, respiratory rate that you're bringing that in. But then in order to get the good stuff in and the bad stuff out, then we have to go through a process of starting with our lung inflation and deflation, but then also diffusion across that alveolar capillary membrane and how important that is to get the oxygen into the body. And then we have to look at perfusion. Do we have blood flow that's going to pair with the air that we're bringing in? And if we don't have that pairing, then we're going to have a problem, right? We're not necessarily going to get the oxygen attached to the hemoglobin and then around the body to transport. So there are these different steps that we can have a problem at any single one of these stages, and then the wheels fall off the bus, essentially. So really, when you look at respiratory patients, all you need to do is really look at those 4 stages and figure out where the problem lies. And then you're going to just apply your treatment to that. Is it a problem with them just not actually breathing? Well, that's a problem. Everything's not going to move if step 1 isn't happening. Or is it maybe that they are breathing, but then the problem is that alveolar capillary membrane and we can't diffuse across that membrane? Then that's going to maybe take our train of thought in a different way. Versus if it's a hemoglobin problem and we're not transporting, then we know where we're going to go. And it's usually pretty simple once you start to just assess your patient to see where that issue lies and then titrate your therapy to that.
Love it. You basically just like danced around the topic of VQ mismatch. I feel like that phrase makes people like, oh, I don't get that stuff. I don't know about this VQ mismatch stuff. What are they talking about? Do you mind just taking a second explaining what the VQ mismatch means and how we combat it maybe?
Yeah. So, and I totally get what you mean. The term VQ mismatch just makes it seem so much scarier.
Right. Who decided on that's what we're going to call it? That's such a stupid thing to call it. Why the Q?
I'm going to use an analogy that one of my good friends actually used, and I think it's a really good one. So if you want to take money out of the bank in order to go buy something, first of all, you have to make sure there's money in the bank, right? So think about that paycheck that's coming in as you're breathing. Like you need to have that paycheck that's coming in, at regular intervals to make sure that you have enough money to be able to spend. But then you have to actually go to the bank and get the money out. And if you actually don't do that, you're not going to have it in your hand when you go to the store to buy something. And that is the idea of VQ matching. So we need to have the ventilation, the air that's coming into the lungs, to actually have blood flow to that alveoli where the air is in order to have the blood and the hemoglobin get the oxygen to be able to transport. So if you have a problem on either side, there's an issue. And a lot of people look at only the two extremes of the situation when they're learning this, but there can be variations within the level. We could have a little bit more blood flow and not quite enough ventilation, or a little bit more ventilation, not enough blood flow, and have like different levels in how much. It could be that we have a little bit of money, but not enough to buy something. And that can very much be a problem. So it's really just looking at making sure we have enough ventilation in an alveoli that it actually has blood flow in order to match up so that every single hemoglobin that is going past that alveoli has enough ability to pick up oxygen and get rid of CO2 in order to have that matching.
Love it. Okay. So from here, let's maybe start low interventions and then go into like the big interventions like the ventilator. Okay, so let's just do a scenario. A patient is working hard to breathe, oxygen saturation's like low 90s, not the best pleth. And so we decide, let's get an ABG to see what's going on with this patient. Because we need to decide, does this patient, are they going to be okay with just this regular nasal cannula? Or do they actually need a higher flow? Or do they need a little bit of positive pressure to help them out as well? So if you could break it down real simply for someone who maybe never touched a ventilator, what are some things like patient presentations and maybe ABG findings that would make you say, okay, we should do heated high flow for this patient, or we should go with BiPAP for this patient?
Yeah. And I think when you come down to this idea of like remembering that when we're getting rid of CO2, and this is going to make sense in just a second, but when we're getting rid of CO2, it comes down to how much air we are exhaling over time. So I like to use an analogy of bailing out a boat. So if you have a boat with a hole in the bottom and you have water that's filling that boat, imagine that water is CO2. So as that water's filling up and you are trying to bail that water out of the boat so you don't sink, right? We don't want to sink. We want to stay afloat. So you have to bail. You have to take a bucket, scoop up water, and shove it out of the boat. That bailing is going to be like breathing. Every single breath, you're going to pick up as much water as you can and dump it out of the boat. Now, if that water or that CO2 is rising, is increasing, you have really two choices when you're bailing that boat. And that's going to be either bailing faster. So you're going to take the same bucket, but you're going to take more scoops every single minute to try to get on top of that accumulation of water. Or you could actually bail at the same speed and get a bigger bucket. Now, that's the exact same concept of when we're breathing, of how we are clearing CO2. We're getting rid of CO2, and it can either be how often we are breathing or how big a breath we are taking. And that's that exact same analogy to how fast you're bailing, respiratory rate, or that bucket size, which would be your tidal volume. So when you have a patient that is presenting and they're not breathing really well, we have to look and see whether it's a problem with CO2 clearance. And you can usually look at a blood gas in order to see that. If you look at a blood gas and you notice that your CO2 is high, think of that boat with the rising water, that means that patient is not getting rid of that CO2 or bailing effectively. So they're not able to compensate enough. Maybe that respiratory rate that they are increasing is not enough. So then you're going to have to look at a support that's going to maybe help them offload CO2 a bit more. And it comes down to whether we can help improve the bucket size. Can we improve the size of their volume to clear more CO2 every single breath? So that's the CO2 side of things versus oxygenation. Then it really comes back to something super scary sounding, but very simple, which is that diffusion capability of oxygen in the membrane, because we usually bring enough oxygen in. Like we really do. We don't use a lot of oxygen even at baseline. So really it comes down to this concept of fixed law of diffusion, and don't get scared. I'm going to simplify the crap out of it. Comes down to oxygen being able to move across the alveolar capillary membrane from either a concentration gradient. So things move from high concentration to low concentration. We know this. We want things to be even. So when you think of osmosis or anything, I like to think of a slinky, to be honest.
Okay.
If you have a slinky and you have each side of a slinky in your hand, in each hand, and you have your hands even, the slinky is going to be kind of curved in a half circle, sitting in your hand, not doing anything. If you raise your hands back and forth, up and down, up and down, up and down, what's the slinky going to do? It's going to start to shift back and forth in your hands, right? High to low, high to low. It's that concept that concentration gradients move molecules and move things like oxygen. So if we have more concentration of oxygen in our lungs compared to our bloodstream, it's going to force more oxygen across. How do we improve the concentration of oxygen? We give oxygen, 100% oxygen or high oxygen, and that's going to increase the amount of oxygen concentration within the lung compared to the body and push more oxygen across. And the other concept of Fick's law is going to be affecting that membrane itself. We know if we're pushing through something that's thicker, we're going to have a lot more trouble to be able to push that oxygen across that membrane. But if we're able to thin that membrane out or increase the area or size that we can diffuse across, that's also going to help. And we can do that by increasing the pressure of the lungs. It's going to expand and inflate the lungs. And you can think like a balloon. When you think of a balloon that's deflated, that rubber, you can't see through it. It's thick, right? But if you blow up a balloon all the way, it's almost translucent, right? You've thinned that balloon out. So if we're able to stretch our lungs and increase the size, it's going to thin that membrane out and the oxygen molecules are going to diffuse a lot easier. And so that's what we can do to help with. If it's an oxygenation thing only, is we can think about those two things, concentration gradient or stretching out and thinning out the alveolar capillary membrane, which is done with pressure.
That is so good and so simple. Okay. So with that in mind, what ABG findings or clinical presentations would you be like, oh yeah, heated high flow is what they need? And then on the flip side, when do you say, oh, I think we need some positive pressure to help this patient?
Yeah. So I think it really does come down to the ABG, to be honest. When you're looking at the ABG, if you notice that your oxygen is the only thing that's a little bit off, and let's say that you have a patient who's SpO2 or oxygen saturation, when you check on their finger, it's sitting lower than you want it to. So a normal healthy patient, usually 92% is that threshold. We want them to be over that. Some hospitals say 94 for a normal healthy person. And then those COPD patients, we're normally sitting 88 to 92% is where we want to be. No higher than 92, but really greater than 88. So if that number's low, but our patient is looking like they're breathing okay, they're not necessarily looking like they're working too hard. They're just oxygenating a little bit low. And we check that blood gas, that venous blood gas or arterial, and we notice that the CO2 is pretty much within the normal range. So they're not having a problem with clearing CO2. It's just the oxygen amount that's a little bit low. So that patient, we can usually quite easily support or fix them with a little bit of supplemental oxygen, even like nasal cannula, to see if that helps. Let's say they're working a little bit and they are a little tachypnic, but their CO2 is fine. They're compensating. They're bailing enough, but that oxygen is still low. We've tried just concentration gradient with supplemental oxygen. So then it's like, okay, can we go for a little bit bigger of a gun? And that little bit bigger of a gun is going to be high flow. So we don't have a CO2 problem. We don't have to give them a bigger bucket to bail. We don't have to go for a bigger breath yet. Here, what we want to do is we just want to give them a little bit more support with oxygenation. So using high flow, we can give them up to 100% if we want, but then what we can also do is skyrocket the actual flow itself. And this does a few things. The number one and really true mechanism that this helps with is that constant flow that we're going to supply is actually going to flush out the nasopharynx, the oropharynx, the upper airway with pure, beautiful, unpolluted oxygen. That even when the patient exhales, that constant flow is just going to even clear the CO2 that usually is sitting in our upper airway with fresh oxygen. So when they go to breathe back in, there's no ability of them to rebreathe any CO2 that might be kicking around in their upper airway that even you and I do, but we're fine with. And it flushes out anatomical dead space. That's the official terminology for what it's going to do. And then there is a little bit of a theoretical idea that if we exhale against a constant high flow, we have a teensy bit of back pressure. But there is a little bit of hand wavy, maybe a little bit. So really, The main thing to focus on is that it's going to flush out that anatomical dead space of the upper airway that normally a little bit of that exhaled CO2 is kicking around with, so that it just helps the patients take that oxygen in at a higher rate and ability, and it's nice and clean and fresh and as high concentration as we need to in order to support that work that the patient's doing.
Love it. Okay. So if we have a little bit of a low sat, but the patient's not working too hard, we can give just like regular flow, supportive oxygen, 2, 3, 4, 5, maybe 6 liters of oxygen flowing into the cannula. But if they're working pretty hard and need some extra support, we could give higher flow through the heated high flow nasal cannula. Okay. But let's say we have a patient who's working pretty hard. Maybe their oxygen is a little bit low, or maybe not. Maybe it's fine, but their CO2 is high. Using your bailing bucket analogy, which I love, by the way, what is the benefit of giving someone like a BiPAP or a CPAP?
Yeah, we'll chat about BiPAP specifically here, because I think that's really the bang for the buck that I would suggest. So one fun thing, that flushing out of an anatomical dead space that I just referred to with high flow, it does a little bit help with decreasing how much CO2 patients breathe in because you flush out that upper airway. So let's say that their blood gas was so incredibly close to normal, but just a teensy bit off, and the patient looked okay. You could maybe attempt with high flow to see if it was enough to support that little bit of work of breathing, clear a little bit of that CO2, give them a little bit of oxygen, which you could even dial down if they didn't need it, and see how they do. But if that CO2 is still continuing to rise and you maybe repeat the blood gas, or maybe their work of breathing starts to look a little bit worse, then going back to that analogy of bailing out the water, you have to now step in. Now, you have a patient who is still awake and talking to you, because those are the rules, right? If they're not, then that's a whole other ballgame, and we're going to have to intervene a little bit more aggressively. But as long as they're appropriate and they're just working, we can't force them to breathe faster. Like, there are limits to what the human body can do. And at the end of the day, that leaves us with one thing, increasing the bucket size. So we want to try and augment how much tidal volume that patient's getting, because if they take a bigger breath in, they're going to also give us a bigger breath out and get rid of more CO2 with every single breath. So this is where BiPAP is the absolute king of all therapies, or queen of all therapies, because what you can do with BiPAP is, with that positive pressure, you are going to, when they go to take a big breath in, the machine is going to push extra pressure when they breathe in. So we have in the lungs, the diaphragm pulling and causing a negative pressure to bring flow into the lungs, at the same time that we also ramp up the positive pressure we apply. So it would take their normal breath and like augment it times 2, because we're doing 2 things in tandem, pulling negative and pushing at the same time. And the analogy I love for this is to think about trying to open a heavy door. And you're pulling and it's a really heavy door. But let's say someone on the other side pushed at the same time that you pulled. It makes it a lot easier for you to open that door, but also open it a lot wider. And that is exactly what BiPAP, what that extra pressure during inspiration is going to do for you, with augmenting tidal volume and then increasing CO2 clearance.
That's good. I love it. Okay. Moving right along. When is it time to say, you know what? We've tried the heated high flow. We've tried the BiPAP. The patient's ABG is still X, Y, and Z. It's time to intubate the patient. Can you just talk about that transition of therapies?
Yeah, this is going to be very patient specific, because there is so many implications to different things. Like, it could be something as simple as what the patient's wishes are, right? Like we have to think about that, and always being patient-centered in our approaches on what makes the most sense. Then there is also, on the other hand, is there implications to intubating that patient that would actually put them at a disadvantage? And one patient population specifically that I would be thinking about there would be our COPD exacerbations, where we really want to avoid intubation if we can, because they do kind of start a little bit behind the 8 ball with their respiratory muscle function, and it puts them at an increased risk of having long-term complications. It's going to keep them in the ICU on a mechanical ventilator for a little bit longer, and maybe not even coming off. So there is a little bit of that we might delay or get a bit more creative, maybe adjust our BiPAP a few times for those patients. Also, other pathologies that really should be able to turn around quickly with medical management, we may as well just start to titrate, maybe increase those pressures and see if we can band-aid, like thinking about our flash pulmonary edema patients, congestive heart failure patients, that they really should be a quick turnaround if we can medically manage them. But if you're thinking about maybe a really sick septic patient that you gave them a shot on non-invasive, but most likely their clinical course is going to be a little bit more protracted. They're not going to get better in a few hours. They may get worse before they get better. If they're not starting to respond, then there's that judgment call of, okay, are we moving in the wrong direction? Now, if something dramatically changes and all of a sudden their level of consciousness goes and they become very obtunded and they're not waking up and they're not protecting their airway, meaning like they're really at the point where they're at risk for aspiration, that's usually going to buy a ticket straight to intubation in the ICU. So that might also come into play. Or it could just be clinical course that they are getting worse and worse. We've tried to increase. They're probably going to get worse with what's happening, what we see in the x-ray. And we just say, okay, this isn't working. Let's just go ahead and intubate them and see if we can be a bit more effective with taking over and normalizing what's happening in the blood. And then they can come back and take over once they're a little bit better.
Okay, perfect. So we've made the decision to intubate. You, as the respiratory therapist, how do you decide between pressure ventilation versus volume-centered ventilation modes? Like, how do you make these decisions? We kind of just see you like tinkering around the ventilator and like, I let the expert do her thing, but I'm curious how you come to these decisions.
Yeah, can I tell you a secret?
Sure.
When it comes, and this is really not a secret, but it's kind of a secret that maybe the RTs don't necessarily talk about. When it comes to true pressure control and true volume control, tomato, tomato, like it really is pressure equals volume. Volume equals pressure. We are pushing air into a closed system. When we have a patient who's intubated, it essentially is a closed system with a balloon on the end. If you blow through a straw into a balloon with pressure for time, you're going to inflate the balloon to a set volume. And if you blow a set volume into a balloon, that's going to mean you are applying pressure for a certain time. It is just two different ways to describe what we're going to do. And at the end of the day, a machine like a ventilator has a turbine that creates flow in a closed system that creates pressure. And we're just deciding what thing we're going to control. And whether it's the volume that we achieve, which usually means that the flow we're pushing in is the thing that's being controlled, or if it's the pressure we're applying for a time and the volume is going to be the thing that kind of varies on the other side. So really, it just, same. We can't be control freaks in ventilation, and we just have to decide what we're going to control. But a skilled clinician can really do the same thing in either one at the end of the day.
All right. Thank you for letting us into that secret. Because I think early in my career, I thought you guys just had this like specialty knowledge, like this ABG equals this setting I'm going to choose. And obviously you do have that specialty knowledge, but like, it's good to know that you kind of just can go either way as far as choosing your settings.
Oh, yeah.
Okay. Let's get back to your pet peeve. Can you talk about the idea of like, is control ventilation rest? Like, what are people getting wrong about the idea of resting the lungs?
Yeah. And like we've talked a lot about physiology and breathing and like the purpose of the human body. And when it comes to using a mechanical ventilator, like the most important thing that we have to think about as clinicians is titrating our ventilation to try to fix physiology as best we can, to put a Band-Aid on it, essentially, until the human body starts to normalize. But we really are trying to mimic what normal should look like for that patient. And that's going to be with every single setting that we're using on the ventilator. It's about trying to mimic physiology.
Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So, if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes.
So when we initially put a patient on the ventilator, the first thing we have to do is we have to ensure that we are supporting what the body needs, achieving, another fancy word, homeostasis. That's just enough oxygen in, enough CO2 out to get the body to the point where the cells are fed with their gas, the oxygen, and we're clearing out the waste because the human body will not function if either one of those two things are not satisfied. So that's the first thing. So usually when patients are first intubated, that's the problem. The problem is that homeostasis is out of whack. We're either not getting enough oxygen to support the organ function that we need to do to survive, or we have a problem with we're not clearing that CO2. And as soon as that starts to go down the wrong trajectory, again, the cells are going to stop functioning the way they should. So when we step in with initially taking over someone's drive to breathe, we sedate them, we paralyze them, we put the breathing tube in. At that point, they can't breathe, and we put them into the machine breathing for them. But realistically speaking, after we get them to a point where the paralysis is wearing off, we keep them in a mode like a control mode that ensures that we are working towards clearing enough CO2 and getting enough oxygen in. But if the patient wants to start to participate, that's a good thing. That's a very good thing. Because what we really want to do is mimic normal physiology. And what isn't normal physiology is going to be sedating and paralyzing patients. That is the opposite of normal. And as soon as we can get that diaphragm working as well and starting to create negative pressure in the chest, it's going to end up helping us ventilate more effectively and not have to work as hard to inflate the lungs because we have normal physiology working for us. So it all comes down to, as long as our patient is safe and not harming themselves by trying to participate, we should let them, because that's going to actually work in their favor and mean that we don't have to apply as much pressure and damage to the lungs in order to achieve the goals that we want to.
That's good. So you had mentioned that we want to allow the patient to kind of take their own breaths and participate. Are there any circumstances when you're like, we're going to take that away from you? You're not doing a very good job in your participation. Your contribution is making things worse. What patient populations would be like, maybe we should not for you?
Yeah, so for patients that we take that away is usually, number one, if they're going to be harming themselves. So one, that's really the reasons, if they're going to be harming themselves with breathing. So one of the patient populations would be a super severe asthma patient that we are intubating them. And again, we try our very, very darndest to avoid that. We don't want to have to intubate them. We try to Band-Aid with everything else. But once we get to that point, the worst thing, the root of all evil when it comes to patients with asthma is going to be auto-PEEP. And the faster they breathe, the worse the auto-PEEP gets. So we need them to not breathe. They have lost their breathing card because we need to slow them down. And really, the rates that we're going to have to use for an asthma patient are going to be way lower than the human body will want to breathe. So if they're able to breathe, they will just auto-PEEP themselves to the point of not breathing anymore. So they've lost their breathing card. They don't have any ability until we break that bronchospasm, and then they can start to participate. And then again, you can quite quickly get them to the point where they are taking over completely and extubated. So that's number one. And then the other, big patient population that we often see this would be our ARDS patients. And the main reason for this is that the lungs are so damaged that their risk of causing self-induced lung injury is really high. We have only small areas of our lungs that are working, but the patient starts to work harder. And when they do that, they end up overinflating or causing extra swings in small areas of the lung, but not in other areas. And they can end up kind of exacerbating the pathologies. And you normally see that with strong increased work of breathing on these patients that normally we're like, ooh, okay, Probably not a good idea. We need to decrease their oxygen consumption, get them not working as hard, and put them deeper, put them out, most likely paralyze them and prone them and do all the things.
Okay. Yes. That's a whole other Pandora's box I would love to open with you at another time for sure. ARDS is one of my favorite pathophysiologies to talk about when it comes to critical care. Okay. So back to the concept of let's put the patient on the ventilator to rest the lungs. Anything else that you want to say, maybe myths you want to bust or like perspectives you want to offer so that we're really getting a good grasp of what the ventilator is actually doing to help the patient?
Just really focusing on that control ventilation is like the longer we do it, minutes, hours, they count. When a diaphragm is not working, when a patient is not participating in breathing, like there have been studies looking at, the ability of the diaphragm to maintain muscle function and tone. And even 18 hours of mechanical ventilation, there are certain individuals that can lose a significant portion of their diaphragmatic muscle. And that muscle is what we need to freaking live. That is how we breathe, right? So we need to maintain that as best as we can. We need to keep that muscle working and conditioned. So when you think of this concept of taking over, letting the patient just quote unquote ride the vent or not breathe and just take over their breathing and let's just sedate them and let them quote unquote sleep and then let the machine breathe for them. What is happening behind the scenes is that muscle is dying and you are letting that muscle decondition and die. And then that puts the patient at an increased risk of prolonged ICU stays, prolonged weaning, and not getting out of that hospital and getting mobile and working. So anything that you can do to restore actual sleep, keeping patients awake, mobile, and participating and breathing is going to work in your favor and their favor.
Love it. Okay, so let's talk about patients that are recovering, and we have been, slowly adjusting the vent settings to give them more of their breathing card back, let them kind of like participate more and more in their care. And we're doing a spontaneous breathing trial. Can you talk about what that is? And then as a respiratory therapist, what are you looking for to decide, okay, this patient passed the spontaneous breathing trial or we're not quite ready. Not quite ready to take the show on the road. What are you assessing for as the RT?
Yeah. So for those that don't work in the ICU or don't have any familiarity, what we're talking about here is like back in the day, like when we wanted to just like take someone off the vent, like we literally would just from control ventilation, they would just yank the tube. Let's see what happens and just see how it went. And there's quite a number of patients that did not do well. So through the years, we've gotten to the point where we start to kind of take away support a little bit here and there. And even that concept has shifted. So it used to be that we would like do little increments where we would decrease, let the patient do a little bit more and more and more. But now pretty much every single day, we assess the patient to say, okay, are they hemodynamically stable? So they're not like their blood pressure isn't in their boots. And is their vent settings not too scary? And usually what we mean by that is, are they on lower oxygen concentrations? Usually below 50%, and PEEP levels. So that's that end pressure once a patient breathes out. If that number is usually 10 or below, that's pretty much our criteria. Those three things, hemodynamically stable and lower oxygen and PEEP. And then if those things are satisfied, we'll just go ahead and be like, okay, let's see if the patient can just breathe on their own. So the nurses turn off sedation every day and we put them onto pretty much minimal, very, very minimal support. And it depends on where you work, what that exactly looks like, but a fully spontaneous mode with the lowest support that hospital uses. And then we just see, it's a vibe check. Are they going to do okay if we take the support away? Or are they going to be like, nope, not ready? And what would that look like? Well, the patient their eyes would open and they get really anxious and diaphoretic and their heart rate would go up and their blood pressure goes up because they're working. They literally would look like they're running a marathon. So work of breathing goes up and they start to huff and puff. And that would be what we look for. We would look for a patient that a normal function, like going for a walk with your dog, you should not look the same as if you were about to run a marathon, right? Personally, I don't run marathons. So if I was going to run on the treadmill for like 5 minutes, that should not look the same as when I take my dog for a walk, right? So that's the difference. They should be looking like they're going for a walk with their dog versus like huffing and puffing and working.
Okay, got it. So at what point Are there any values that you're looking at as far as like, what is their respiratory rate or changes in their oxygen saturation? Or what are you looking for to be like, okay, you pass versus you don't?
Yeah, and this is a really great concept because this is something that I find I struggle with chatting and talking to other clinicians when it comes to spontaneous breathing trials. Because we look at a patient who's on full ventilation and the machine's breathing for them. Sometimes it looks like they're super comfy and they're riding the ventilator and they're chemically restrained. They are sedated. So they are in a coma. And then when we lighten them up, just like you when you're sleeping versus, and even please don't misconstrue sedation is not sleep, but if you're sleeping at night, your respiratory rate is not the same as when you are awake. We breathe faster when we're awake. Now, when we wake that patient up, they're going to start to breathe faster. So when they get put into that spontaneous breathing trial with minimum support, their respiratory rate might go up. Their heart rate might come up a teensy bit, or their blood pressure, because now they're awake and looking around and what's going on. Oh my goodness.
Yeah, their metabolic demand has gone up because now their body's moving and they're aware. Yeah. And yeah, there's definitely a little bit more work to be done. So the body has to compensate by breathing a little bit faster.
Yeah. And I think a lot of people that are used to seeing their patient breathing at a rate of 12 or 13 on that control mode when they were chemically restrained versus on a spontaneous breathing mode with a respiratory rate of 22 to 24, but good volumes, not huffing and puffing, but breathing faster. And maybe that heart rate came up a titch and blood pressure a titch, but realistically speaking, they're still within normal ranges. That's a pass. But a lot of people look at that increased respiratory rate compared to what they were doing and said, oh, they're getting worse. But really, when we look at failure, we look at a respiratory rate that's less than 30 as a pass. We want to see that respiratory rate lower than 30. And as long as those volumes are adequate and the patient is not huffing and puffing, and our saturation, blood pressure, and heart rate has not increased by 20%, that's a pass. Even if their rate went up a little bit, that is not a fail. You have to recognize the difference as the patient's taking over. And you also have to ask yourself if maybe their intrinsic respiratory rate was always that 24. And before you just missed it, because you can have missed efforts that are hiding in those control breaths that you don't see.
Yeah. Okay, good. The last myth that I want to talk about, because it comes up all the freaking time, is managing COPDers. And you kind of talked a little bit about it, that we're okay with an SpO2 of like 88 to 92 for those patients. But I've shown up to patients who are sitting at 70%, and the nurse is like, well, I didn't want to give them oxygen because I didn't want to knock out their hypoxic drive. Can you just speak to that for a minute? Like, what's really happening and how do we actually manage these patients?
I so feel your pain because this myth will not die. It's one of those within nursing school that I wish I could just tour the country and just go to every single nursing college and be like, this is out of your curriculum, yes? Okay, so let's take a little trip. Let's get in the car. Let's go back in time just for a little bit. And let's talk about where this came from, because that always helps when you tell people where it came from. And they're like, I feel like an idiot. I had no idea. So there was a study that was released in 1950 that had 5 patients included in this observational study, where a doctor wrote up this study based on 5 patients that he just watched and wrote about what he saw.
Wow.
That's it. That's where it came from.
Okay. So not high-level evidence here.
No.
Okay.
And from the 1950s. So actually think about that, guys. That's not 50 years ago. That's like 70 years ago. That's a long time. Medicine has come a long way. Like that probably is closer to leeches and bloodletting than it is to what we're doing now. Like that is a long time. So that's where it came from.
Okay.
So with that context in mind, let's dive in a little bit. What's actually happening is when it comes to how the human body normally breathes, like if we give every single patient high amounts of oxygen, you, me, everybody around the world, it's going to cause our CO2 to go up a little bit. Now, COPD patients are really fragile and they can't handle that slight increase in CO2 that would happen to every single person. And I'm going to get into that increase in just a second, but stay with this. COPD patients already, if they're at a disadvantage and their CO2 levels are a little bit higher, that slight increase from oxygen is going to then put them to, oh, that was the straw that broke the camel's back, and they can't compensate enough anymore. And that's why they can then get into trouble, that their compensation that they've already exhausted because they're at a bit of a disadvantage, then that straw that broke the camel's back of extra oxygen is what puts them in the position that they can't compensate anymore. So that's kind of what's happening specifically with COPD patients. But coming back to this idea of why every single patient is going to have slightly increased levels of CO2 if we give them too much oxygen, it's from the ability of gases to move around the body. And essentially, when we transport oxygen, we all understand that we attach our oxygen to hemoglobin, and that's how it moves. But CO2 also binds to hemoglobin. And that's also partially how CO2 moves back to the lungs. And when we have oxygen bound to hemoglobin, it's going to decrease the CO2's ability to jump on and move back. So staying with that idea, if we have a lot of oxygen that every single patient's getting, a high concentration, we're not going to use anywhere near that amount of concentration of oxygen because we're giving too much. So if you threw someone with a SAT of 90% on 100% oxygen, their SAT's going to go to 100%. But that could mean that the amount of oxygen circulating in their body is like enough to fill a truck. They're not going to use it all. So the hemoglobin will never be without oxygen. It's going to always have oxygen bound to it, meaning that 30% of CO2 that normally jumps on when the oxygen offloads to come back to the lungs to be exhaled has trouble binding because that oxygen is still kicking around because it hasn't offloaded all of it at the tissue. And so that CO2 is going to stay at the tissue level and increase slowly over time. And if the body can't compensate for that by breathing faster and increasing that tidal volume and bailing that boat more, then we run into trouble. So every single person has that slight increase in CO2, but then our compensation mechanism is able to kick in because we haven't exhausted it. You and I breathe faster and deeper and get rid of that CO2. But that poor COPD patient that was already in an exacerbation, that was already tachypnic, and that was already, maybe battling a little bit of an pneumonia and not doing so well, that little bit of extra of a problem, they don't have any more to give. They're at their limit. So their CO2 level climbs even higher. And then they get into the trouble where their pH is so bad that the cells stop functioning the way they're supposed to.
Gotcha. So the way that I have understood it is that, yes, COPDers live at a higher CO2 level. And yes, they don't need an oxygen saturation as high as the average person because they're so used to being low. But that doesn't mean we don't give it to them if they start becoming hypoxic. They still require it, but it's just extra important in the patient population not to overdo it with oxygenation. So we just need to be okay with the fact that they're 88, 92 versus trying to get them to 100%. There's no need for them to be at 100% unless you're about to intubate. There's no need to hyperoxygenate these COPD patients. And we're not so worried about giving them oxygen to the point that they stop breathing. We're just worried that if we give them more oxygen than they need, then there won't be space on the trucks to get the CO2, the 30% of the CO2 that's going to head back to the lungs to be exhaled out.
Yeah.
Am I understanding that correctly?
That's perfect.
Okay.
That's absolutely perfect. So I think that the key messaging here is remembering what do we do with respiratory interventions? We're mimicking normal physiology. So it's really not that 88 to 92 is magic. It could be that 94 is okay. It could be that 96 is okay. It could just be that 100% saturation. Once we get to that number, we don't know how much more we're giving. We don't want to ever be at 100 because we're blind. We can't get to 101 or 102. But realistically speaking, your PO2, or the amount or concentration and partial pressure of oxygen in your blood at a saturation of 100% could be anywhere between, 90 to 400 or higher. We don't know. So really, you and me, us normal physiology people, we normally try to keep ourselves around 92 to 99. That's where we want to be. We don't want to hit 100 because, again, that's the blind spot. We don't know. For COPD patients, it's really not necessarily that greater than 92 is dangerous. It could be that their normal saturation at home is 93, 94, and that's okay for them. But We try to be extra uber cautious because we don't know these patients from a hole in the wall when they come in. We don't know what their normal is. So we tend to err on the side of a little bit of caution, but we cannot allow them to be hypoxic because that is going to cause way more problems. And those patients cannot compensate for hypoxia. Remember, they're working hard. So we have to give them oxygen, just not too much. So 88 to 92 is that safe place to be. We absolutely know that there is no danger of being higher than their normal. And it still is a physiologically comfortable place to be and being cautious. Did that make sense, Sarah?
Yeah, no, that's good. Thank you for helping me clear that one up because I hear it all the time still. All right, we've done a good job of smashing some old dogma and talking about some maybe misunderstandings of very old knowledge. Is there anything as we close about like the role of the RT that you feel like nurses don't see or don't appreciate, or like anything that you want the nursing community to know about how you work, how we can collaborate, whatever you want to share there?
I have to say that by and large, I think the nurses, and I said at the beginning of the podcast, I think nurses almost give RTs too much credit sometimes. We're just like, I'm in awe of nurses, the amount that you guys have to know and do, and how variable you have to be into different pathologies and situations. Like, I am so lucky. I really have one major system and then it touches on, some of the other ones. But at the end of the day, it's quite simple to stay within the expertise of heart and lung. It is an easy place to be. So I feel like sometimes we're given too much credit. Nurses need to give themselves credit, empower themselves to stand in their ability to drive the decision making. And sometimes working in collaboration with the RTs to be like, hey, this is what I would do. Like, what are your thoughts there? Like, am I on the right track? If you weren't here and I did X, Y, or Z, is that what I should be doing for my patients? And I promise you, the RTs will probably really get engaged and challenge you guys with some scenarios and situations where you can start to learn and feed off each other and be able to work more cohesively as a team.
Yeah, absolutely. I just want to echo that and say, nurses, ask your RTs what they're doing. If you see them in your room messing with the vent, if they're tinkering with things, just go ask, like what you doing? Not in an intimidating way, but just teach me what you're doing. Like, how are you making these decisions? What are you working towards? Like, what parameters are you watching right now that I'm not seeing? What is this waveform on the ventilator? All of these things I did not learn in nursing school. I learned them from talking to my colleagues about taking some of their expertise and trying to put it into mine, because there's so much that we are not taught. Like, oh yeah, that's what the RT does. The RT will take care of that. And they will. But I feel like we can collaborate so much better if I know what you're up to, if I know where you're going next, if I know what you're trying to check off your list or what things you're trying to work through, so that we can be communicating about, speaking the same language about the patient. I totally agree. Well, Melody, this has been really good. Thank you for bringing clarity, some much needed truth bombs to the world of ventilation today. I know that a lot of the nurses listening are going to walk away with a deeper understanding of how vents really work, how to partner with our RTs more effectively, how to stop some of this old dogma from being passed down from generation to generation. Speaking of, if you learned something today new in this episode, don't gatekeep it. Go ahead and share it with a friend, because it might help them at the bedside and ultimately improve patient care. Melody, before I let you go, can you just tell my audience how they can find you?
Yeah, if you want to find me on social media, Melody Bishop _RT is my Instagram handle and TikTok handle. And I'm also on Facebook, pretty much the same handle, Melody Bishop RT. Also, if you want to go to my website, again, melodybishoprT.com, that I actually have a free book that is meant to be the very basics of mechanical ventilation. I wrote it during COVID for nurses, for paramedics that have zero training. And it will literally walk you through in very simple analogies. Some of the analogies I've used today are from the book, in order to help you start to understand this wild and wonderful world with the very, very basics that you can then grow and learn more and ask your RTs. So if you go to my website, www.melodybishoprT.com, if you go under resources, free resources, you'll see you can download an EPUB, you can download the PDF, or you can read it online. And it is absolutely 100% free. And just, again, don't gatekeep, share with friends.
Love it. All right, Melody, I will definitely put those links for everyone in the show notes. Thank you so much for your time today. Thank you guys for listening. And as always, stay curious, stay prepared, and let compassion be the driver for how you care for your patients.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.